طيب, Assalamu alaikum wa rahmatullah. Good evening, everyone. I would like to welcome you today to one of SSBD Hematology webinar series. Today webinar about bleeding disorder. We are honored to have distinguished speakers who will share their knowledge and expertise. We have Dr. Magdy Elekiaby from Egypt. We have Dr. Ahmed Tarawah, as well as Dr. Azzah Alzahrani. The program will be 3 talks, each talk for 20 minutes. And at the end, we will have a Q&A. I would like to ask attendees kindly to write your question in Q&A tab. The first talk will be given by Dr. Azzah. It will be about how I approach bleeding tendency. The second will be by Dr. Tarawah. It will be how I manage bleeding tendency. And lastly, we will hear a talk from Dr. Magdy about how I treat Willebrand disease. I would like to remind you that this webinar, as well as many other webinars, are recorded and available in the Society YouTube channel, Saudi Blood in YouTube, or Saudi Blood on Twitter. Without any further ado, it's my pleasure to introduce Dr. Azzah Alzahrani. Dr. Azzah is a pediatric hematology oncology consultant working in Prince Sultan Military City. Dr. Azzah.
Assalamu alaikum wa rahmatullah. Thanks SSBD for organizing this event, and thanks Dr. Feras, Dr. Ahmed Tarawah for inviting me. My talk today about approach for bleeding tendency in children. My slides clear?
Yes, Doctora, it's clear.
So when we talk about the bleeding tendency, we are talking about the definition of hemostasis actually, which this is a physiologically balance between the anticoagulant, pro-anticoagulant, and the other elements to maintain the blood in the circulation in hemostatic status, to prevent excessive blood loss or more clot formation. So the balance between those anticoagulant and the procoagulant, usually if there is any exogenous or other risk factor, it can tilt this balance toward either to clot formation or bleeding tendency. So when the injury happened to the blood vessels, there is the hemostatic, it happened in coordinated fashion to stop the bleeding, starting by the vessel constriction and recruit more platelet to the area of injury, which it caused platelet aggregation and activated the platelet, assigned more coagulation factor to assign on the platelet and to formation of the clot to prevent blood loss, and as well it's in a fashion matter that to prevent even excessive of clot formation. So when we are talking about the coagulation cascade, we taught previously in the school that it's right and left arm intrinsic and extrinsic pathway. It's actually it happened in a circulation pattern. It started from the tissue factor activation of factor 7 when the injury happened to that area, till ended by stabilize the clot formation by factor 13. Which all the extrinsic and intrinsic pathway it react together in a circulating pattern. So when the bleeding, or we are thinking what's the going on for the disorder, if there is any disorder in the hemostasis, we think either is it vascular problem, which it could be, is it, are we talking about the platelet disorder or coagulation, or mixed, it could happen. So vascular issues, again, is a very important aspect. It's, again, it could be associated with other syndrome like Ehlers-Danlos or Marfan. It could be secondary after infection or due to use of medication like steroid. Distribution of the petechial rash or the berberic rash is, again, it's very important to know what's going on. So the very important to evaluate the bleeding tendency is start with the history. History is very important, followed by physical examination, then laboratory evaluation. The history is very important to look for the this bruises or this bleeding. Is it localized or generalized? Is it spontaneous or induced by trauma? Is it mucocutaneous bleeding, or is it deep joint or deep muscle bleeding? Is it post-surgical? And even if it's post-surgical, is it immediate? So we are talking about like platelet disorder, or is it late? So we talk about the coagulation. So why we are concerned about the bleeding? Actually, it could be life-threatening, and it could be scaring, and it cause more stress for the child or for his family. And we have to know that not all the bleeding disorder due to a disease process. Nosebleed is very common in children as well in adults, and approximately 90% of those epistaxis non-pathological. But we need careful history and to assess. So the best laboratory test actually is the history. The history including the personal history, patient history, and family history for easy bruising, for the mucocutaneous bleeding, and for surgical history is very important, and as well if there is any muscle or joint bleeding. The bruising, when we are talking about the bruising, because we have noticed there is many kids referred by GB because they have bruises in their lower limb, which is sometimes this is common in children because they are, it's induced by trauma when they are playing. But we have to elaborate more how easy those bruises, where is it? Like bruises in the chest or abdomen where not expecting to get a trauma, this is unusual. And how big is this bruise and what the frequent? Of course, a bruise like this, it will not be a normal. Again, epistaxis. When we get a patient with epistaxis, we have to elaborate more. How frequent is this epistaxis? What's how much? And does he need to go to the hospital to stop or stop by itself? Is it from both nostrils or from one side? Does it change with the weather, like in the summer, more in the winter, or like mucocutaneous bleeding? Like this is a study also done in by our colleague in Saudi Arabia, looking for the epistaxis prevalence in Saudi children, which is again is almost like in adults. It's maybe up to 40% they have experience of epistaxis, and most of that is non-pathological, is related to inflammation or to the weather. The other mucocutaneous bleeding, which more significant maybe in the young ladies or in the women, menorrhagia. Again, the menorrhagia, we have to ask about duration, amount of bleeding, and if there is any associated anemia or require blood transfusion. Joint bleeding is significant, or muscle bleeding. Surgery is very important. Like especially if he exposed for area which the most hemostatic challenging area, like adenoidectomy or tonsillectomy, this is very challenging area. Sometimes they refer cases for us that incidentally they found that he has prolonged BTT or something. Then when we go back to the history, he had, like when he was 5 years, 6 years, he had adenoid tonsillectomy without any problem. So unlikely this one he has any significant bleeding diathesis. Family history again is important. We have to ask about family history. If there is any like some like in hemophilia or von Willebrand, history of medication again important. Other symptoms and signs like sepsis or burn, other insect bite. This is again important to ask about it. Physical examination is very important, looking for the petechial rash and barbaric rash, bruises, distribution, the amount, number, clinical status of the patient, all this is very important. Here, I review, this is by Canadian group. They look for and actually recognize, and as us also, the complexity of the coagulation test and how to interpret this result. So they are making a history is very important, and they are trying to standardize a questionnaire for the to assess the risk of bleeding. So the bleeding assessment tool, which is based on the history and questionnaire, and to determining what the coagulation or what the test for bleeding disease we can do. And they are trying to standardize the bleeding history to improve the pre-test probability of the bleeding disease, and to know what the coagulation testing we want to do. And by following this unnecessary coagulation testing, it could be eliminated. And so through the understanding the common homeostatic test and the appropriate history, it could make you more appropriate to select and interpretation of the test. This is some of the guidelines that it depend on the history of the patient and family history, which is year by year they are making more new addition to make it more sensitive and specificity. So this depends on the history of and symptoms of the bleeding, severity and the frequency of the bleeding. It's like in 2005, which is like reflecting von Willebrand, which is the most common bleeding disorder. And by this history, they make it like the sensitivity and specificity maybe it's more than 80%. And when they add also molecular and clinical marker for diagnosis and management type 1 von Willebrand, increase sensitivity up to 100% even before to do any test. In 2010, including also the ISTH, including pediatric and male and female. And the score, it depends again, as I said, about the severity and the frequency of the bleeding. So how we can use the bleeding assessment tool? There is many validated, like the one I mentioned for you, the MCMDM and pediatric bleeding questionnaire assigned. This is they use also in their history, the surgical history, like adenoid tonsillectomy or dental extraction if there is any bleeding. And the ISTH and pediatric bleeding questionnaire evaluated pediatric bleeding symptoms that it happen even during after birth, like cephalohematoma or bleeding after umbilical cord fall down, or if there is any conjunctival hemorrhage. Also, in the women, they assess menorrhagia in very comprehensive way. After the bleeding assessment tool, which is depending on the questionnaire and the history, we have the 5 points to do screening, BT, BTT, and platelet function analyzer, CBC, of course, to look for the number of the platelets. The BT, as you know, testing the extrinsic pathway as well the common pathway, almost the vitamin K, factor 5 and 10, common pathway with fibrinogen and prothrombin. And the BT reading, it will be not linear. It's as much as low factor, it will give you more BT, prolonged more. So in prolonged BT, Usually we look, is the patient on medication? Does he have any vitamin K deficiency or early liver disease? And interesting that the INR in the chronic liver disease, it doesn't correlate with the bleeding risk in those patients. Actually, it reflects the severity and the prognosis of the liver disease. But even if the INR 5 or more in liver disease, it doesn't carry a risk if there is no other risk factor to get a bleeding. Because in liver disease, as the factors, for example, factor 7 is low, also protein C and protein S is low, so it's a balance. So it's not related to the bleeding. Again, it could be reflecting congenital factor 7 deficiency, or an inhibitor is very rare in factor 7. BTT is more actually problematic. One is, and it's very common to get prolonged BTT, and sometimes how to interpret this result, it doesn't correlate with the patient symptoms and sign, but we have again to look if the patient taken from central line, which is heparin contaminated, or it could be just related to inhibitors, or maybe he has contact factor, which is the perikallikrein or kallikrein or high molecular weight kallikrein, canonogene, sorry. So this is, it can give you prolonged BTT with no bleeding symptoms, or the either deficiency of factor 8 like in hemophilia, or acquired hemophilia. But some of the study, they mentioned that the BTT, it could be like the collection, and even the vein puncture, when to collect is very sensitive. The BTT, it can be give you a wrong result for it. So the prolonged BTT, again, like is either prolonged BT or BTT, we will do first step for that mixing study. And if it's corrected, that means factor deficiency. If not, maybe he has inhibitor. But again, sometimes maybe it doesn't correct it because there is some inhibitors, or maybe he has multiple factor deficiency. In acquired hemophilia is a little bit the development of the inhibitor is the curve of the interpret after the mixing study is a little bit different from the allo antibody. Thrombin time, this is mainly testing fibronectin. So it prolonged if there is again heparin contamination, or there is low fibronectin or dysfibronegenemia. Normal BT and BTT, we have to look for the, and there is a bleeding history, look for the platelet number, look for factor 13, and some fibrinolytic system, maybe he has some defect there. So the coagulation defect, usually it gives us a hint by the deep joint or deep muscle bleeding, like in hemophilia A and severe type 3 von Willebrand disease. And the prothrombin also very rare, but it's associated usually with liver disease and vitamin K deficiency, and very rare inherited bleeding disorder. Fibronectin deficiency, it could be related to, again, to liver disease, or in case of DIC, and again, it's very rare to inherited fibronectin. Von Willebrand disease, it's a common bleeding disorder, and my colleague will talk about it. This is the study done in Saudi Arabia. Look for the distribution, prevalence of von Willebrand disease, which is almost similar to, it's maybe higher in us, it's about 1.5%. Platelet disorder, again, it could be a quantitative disorder. A quantitative, it could be congenital or acquired as megakaryocytic, which since birthday will have low platelet number, or familial thrombocytopenia and ITP. qualitative like Glanzmann, Bernard-Soler, or other platelet storage disease. Thrombocytopenia, it can go to non-immune, like in DIC, hypersplenism, or bone marrow problem, torsion infection, metabolic, or immune, either secondary to SLE or lymphoproliferative disorder or sarcoidosis, or if by eliminating all the causes, then we'll give idiopathic thrombocytopenia, which is more common in pediatric age group. To diagnose the platelet, we have to look for smear. It's very important. The size of the platelet can give you a hint, and the shape of the platelet. Platelet aggregation important, and of course the Willebrand antigen is one of the activity, one of the panel of diagnosis of the platelet disorder. Platelet flow cytometry. To take message, family and personal history is very important before to do any testing, and coagulation testing should be performed only in patients with positive bleeding history. BT-BTT are diagnostic tests for inherited bleeding disorder and not a screening test. And this is again in the Canadian group. They look for the pre-operative testing for like the BT. More than 94 of this testing, it's not necessarily, while even in BTT 99.9 is not necessarily to do as a routine pre-operative. So the majority pre-operative BT and BTT testing are unnecessary. And this is the study I did in Prince Sultan Military Hospital, which look also for pediatric age group up to 14 years, from 0 to 14 years, and to look for those they have BT and BTT, and actually the same like worldwide. It's most of those patients, we could eliminate their coagulation testing by appropriate history. So when to consider to do pre-operative coagulation, to do it if the patient on anticoagulant, if he has liver disease, or if he has expecting to have malabsorption like malnutrition, or he is sick like long time on antibiotic, and BTT if he has like cardiac surgery, or he is known to have hemophilia or Willebrand, or he has like SLE or antiphospholipid syndrome. The 5 reasons not to do BT and BTT as a routine, it's not actually, as I mentioned, it's not routine. It's not a screening. It's just diagnostic for suspicion of disease. And routine pre-operative for low risk, like non-cardiac vascular, and I will add non-neurosurgery. So it's not recommended. To monitor like the anticoagulant, some of the anticoagulant doesn't need the BT-BTT, it's working in anti like factor 10A or other marker. Or monitoring prophylaxis, again, we are not doing BT-BTT. So thank you for your listening. Any question?
Thank you, Dr. Azzah. Excellent talk, excellent timing. There was one question. There was a question to write the reference about epistaxis in Saudi Arabia in the chat, if you don't mind.
Sure, I have it here. I can.
So we will move to the. We'll have the questions at the end. Okay. Yeah. Dr. Azzah, you can stop sharing. Okay, our next speaker is Dr. Ahmed Tarawah. Dr. Ahmed Tarawah is a pediatric hematology oncology consultant in King Abdullah Medical City in Al Madinah Al Munawwara. Also, he's an SSPD board member. Dr. Tarawah, the floor is yours.
Thank you. You can see my slides, by the way?
Not yet.
I have a freezed Zoom. Only I can see your picture. Let me try to do it again. Okay, now it's okay.
Yes, we can see your slide now.
Yeah. Okay, Bismillah, alhamdulillah, wassalatu wassalamu ala rasulillah. Thank you, Feras. Azzah, thank you. You have made my mission much easier. And I'm quite happy to be in this session, particularly with Dr. Magdy Elekiaby, the big figure in the bleeding disorder in the world, not only in the Middle East. So this is something huge. I'll go very quickly over it. Bleeding disorder, it's not a matter that to be managed by one person, a hematologist or whatsoever. It's a complex, and it should be managed by a group of people and in a way that patient is centered. In most instances, you don't need to go beyond. Just local measure can stop the bleeding, like nasal backing if there is epistaxis or topical thrombin. But there is some certain measure you need to take care of, particularly avoid of those medications that can cause bleeding or platelet dysfunction, such as aspirin containing products or so, and we need to take care of that. Deep IM injection should be avoided, and very important that every bleeding disorder patient carry a card in his pocket or in around his wrist or so, indicate that what type of bleeding he has, and this is very important to be done in our place. The main issue in the bleeding disorder management is the replacement therapy. This is based on the what type of bleeding disorder, but this is a quick list of the replacement therapy, such as platelet transfusion in plasma thrombocythemia or Werner-Soler, fresh frozen plasma and coagulation factor, maybe like factor 10 or 5 or so, cryoprecipitate, or specific coagulation factor concentrate, whether it is plasma-derived or recombinant, factor 8, factor 9, von Willebrand factor, factor 13, blah, 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 all of those replacement therapy. DDAVB, it is very important to be used. Unfortunately, we don't have this preparation. It should be a special preparation, not the preparation used for ADB, but should be special preparation. And this is very useful for those patients, particularly whom they have milder form of the disease, where it can increase the factor, for example, von Willebrand factor, where Magdy will talk about it in a minute. So DDAVB can do the job rather than to go beyond that. Platelet transfusion, it is very important to be used, particularly in those with platelet dysfunction or thrombocytopenia. And it is preferably in those patients with hereditary platelet problems to be leukodepleted single donor HLA matched as much as you can, because of the easy that those patients, they will develop antibodies. Almost quarter of them, they will develop antibodies against the platelets, and a quite good group of them, they will have a platelet refractoriness. Of course, there is a risk for the platelet transfusion, infection, hemolysis, TRALI, whatsoever, and the new issues. Iron deficiency anemia in children, it is very important to be managed because it is a usual complication of iron, of bleeding disorders. Antifibrinolytic agent, either tranexamic acid, which is available almost everywhere, or aminocarbonic acids. It's available in intravenous or oral or mouthwash preparations, and it is very useful, particularly in those patients who they suffer of mucocutaneous type of bleeding. It reduces the post-procedure bleeding in oral procedures or so, and it reduces the delay type of bleeding. In the mouthwash, I don't think that we have it here in Saudi Arabia, but in some countries, they do have a special preparation of the mouthwash. But if you don't have it, either you can crush the tablet or you can use the IV solution as a mouthwash solution. 7-8, the recombinant activated factor 7 has been started to be used in bleeding disorder in 96, and it is licensed for hemophilia with inhibitors for the Glasman thrombosthenia, but maybe we can use it in some other type of bleeding disorders, do the job, and it has been shown successfulness in stop bleeding whatsoever the type of bleeding, and this is the 2004 Boone study. It has shown this successfulness in different type of bleeding, in different type of surgeries, and in assumption that it has been used in optimal dose. And the optimal dose has been divided more than 80 microgram per kg at interval less than 2.5 per hours for at least 3 doses. Now, we know some studies has shown that the higher dose, like 270 mic per kg as a single dose, it does the job in hemophilia patients with inhibitors. It has shown that it is safe, though the thrombotic event has been reported in 1.5%, but in many occasions, it is used in concurrent with some other type of medication. It's your way to divide how you are going to approach the bleeding episode or surgeries. This is a suggestion from my side that whether you consider the patient as antibodies like antiplatelet antibodies in Glasman and Bernard-Schroer or any other platelet dysfunction, or in hemophilia, anti-hemophilia, or even in von Willebrand, or they don't have antibodies. And the bleeding, whether it is minor bleeding or major bleeding. Usually in minor bleeding, we need not to go beyond the conservative, a local type of measurement or fibrin glow or thrombin Sergicel if you don't have it, and tranexamic acid antifibrinolytic agent, and very rarely that you need to go for the replacement therapy. While in major type of bleeding, usually you need to go for a replacement therapy, depend on the disease you have. If you have factor 13, you will give factor 13 concentrate, or you may use 7A in those type of bleeding if you don't have the concentrate or any other type of modalities. Even those whom they have antibodies, again, in minor bleeding, local measures and tranexamic acid is enough. But if you don't stop the bleeding by this method, 7A, good opportunity to be used. And again, a major type of bleeding with those patients whom they have inhibitor, Glasman, Bernard-Schroer, hemophilia, 7A will do the job, and you have to follow the protocol for it. Surgical management, again, I do divide it the same way, minor surgery and major surgery, whether they have antibodies or they don't have antibodies. Most important, you divide it into what you need to do before op and just pre-op, during operation, and post-surgery. Pre-operatively, you need to coordinate among the hematologist, surgery, lab, pharmacy. Everybody need to be aware that this patient with this bleeding disorder going for surgery. And we make sure that all our medication we are going to use or may going to be used during surgery is available in hand. And we have to be ensured that hemostasis with those medication are there. There is many tests depend on the type of bleeding disorder and the site of bleeding disorder to be done. Most famous of them, TEG, elastography, or RODEM, which is real rotational thromboplastin elastometry, where you can measure it. It is quick test. The result will have it within 15 to 20 minutes. Specificity and sensitivity is good in some disorder, but not that good in some disorder. But this is a very good tool to go ahead and measure how effective the hemostasis will be on this type of patient. Immediately before surgery, depend on the disease, whether you use tranexamic acid or replacement therapy or 7A, and you ask the surgeon to start his operation. And again, during operation, they need to go for the local measure, stop bleeding, and so they may need to use replacement therapy 7A. And again, during operation, particularly major operation, which take long time, you do the test during surgery. Post-operative, you should reassure yourself and the patient that he will not bleed after, and you need to keep them on tranexamic acid replacement therapy or 7A for a quite certain period, depend on the surgery you have done. If the bleeding is expected, take it for longer time, or if it is a minor surgery, you don't expect bleeding, probably 1 or 2 days will be enough. One of the problems face the people with the bleeding disorder is dental issues. It is very known with the mucocutaneous type of bleeding and bleeding disorder to cause gingivitis. And whenever the patient have gingivitis, they will not brush their teeth because it is painful. Whenever they don't brush, it will go again bleeding and gingivitis, and this circle never stop in the bleeding disorders. We divided the risk of bleeding into when they are going to do workup into a low risk bleeding or higher risk of bleeding, and we do our management accordingly. So those with low risk will do a local measure with maybe single dose of 7A and tranexamic acid is enough. With higher measure, we need to keep those patients on tranexamic acid for a longer period and replacement therapy. And this is list of the local measure dentists they will do. Suturing is important in adult, and maybe it is beneficial in some situation, while in children we don't like suturing. I'm talking about dental. Try to do the local measures a part of the suturing. Anesthesia, another issue, particularly when you go for type of anesthesia like the inferior dental block or lingual infiltration or so, which can cause hematomas. So we don't like it again in children, and in adults it should be done under factor coverage. But again, do simple anesthesia like buccal infiltration or so. They don't need to be on the replacement therapy. This is the recommendation from WFH, what the bleeding disorder patient, they need to follow about fluorination or toothbrushing or so. I'm not going to those detail. To reduce the trauma during dental workup, it should be done under certain measures to be reassured that there is no risk of bleeding happening during that. Extraction can be done safely in bleeding disorder patient if we go with the measure such as replacement therapy or suturing or tranexamic acid and plus the other measures. Even in children though, exfoliation of the primary teeth, again, usually we do see them do something as such without bleeding, but if they do so, maybe we use replacement therapy or tranexamic acid. One more thing about the dental, we know all dentists, they are afraid to work on a patient with bleeding disorder because of the bleeding fear and phobia. So just talk to the dentist that you have nothing to do with the bleeding issue. I'll prepare the patient for you before he comes to you and do your job, send the patient back to me and I'll do the rest of the job. This way they will feel comfortable and do their job very well. The gynecological aspect, as Dr. Azzah said before, it is a problem for the ladies with bleeding disorder, particularly menorrhagia, whatsoever the definition of menorrhagia you are going to follow, but this is a real problem among the ladies with bleeding disorders. And menorrhagia by itself, it's a big problem for ladies in general, but most of the patients with bleeding, I'm talking about ladies with bleeding disorder, they do so. For example, in Glasman thrombasthenia, almost 100% of them, they will have some sort of menorrhagia, and this is the rest of the group, including the hemophilia carriers, von Willebrand disease, and so on. This is the rate of the menorrhagia and certain type of bleeding disorders. So it is a common problem among them. We do not know exactly what is the pathophysiology behind the menorrhagia and bleeding disorder, but probably as simple as a mucocutaneous type of bleeding, increased fibrinolytic activities, angiogenesis formation or promotion happen, but still we need to know more about the pathogenesis behind it. Ladies with menorrhagia, they have a big issue in quality of life. Just imagine somebody who has severe bleeding for 14 or 21 days. She cannot go to school, university, work, or so. So this is a big issue. We need to take care of that. Dr. Azzah, she talked about the ISTH path, so I will not go over it. It is very useful tool to measure. This is special for the amenorrhagia in particular, and it is good tool to be used too. History and what you need to do for those patients. Amenorrhagia, when they have in a bleeding disorder, antifibrinolytic is very useful to stop bleeding, and sometimes alone is enough. Hormonal therapy, replacement therapy, platelet, 7A, desmopressin, all are effective to be used in amenorrhagia. We have developed a protocol in Medina, and now the Italian and French start to adopt this protocol, which is simple protocol and allow the patient to get their menstruation, though we don't stop for them with hormonal therapy or so. So particularly in our Middle East communities. This is a scheme done by James from the United States that what you need to do for each patient if they want to preserve their fertility and they want to be pregnant. So you need to manage amenorrhagia with tranexamic acid 7A platelet replacement therapy. If they don't want to be pregnant right now, you can use hormonal therapy. If they don't want to be fertile, we go for hormonal therapy. If they don't want to be fertile at all, maybe we go for hysterectomy or endometrial ablations. This is the regimen for the hormonal therapies. You can choose whatever you would like. Pregnancy, another issue for those ladies, and we do allow them to go for pregnancy, though they have a problem. Their neonates products, they have a problem. So risk of miscarriage, particularly in factor 13, or Glasman or fibrinogen problems is there, a placental problem is there, and we need to manage those patients preconceptionally, antenatally, and during pregnancy, and we need to manage the spotting during pregnancy as a minor hemorrhage, or maybe we need to do it as a major hemorrhage, which I spoke to before. Delivery should be very well planned. We try to avoid the spinal type of anesthesia. We try to avoid prolongation of the second stage, try to avoid the ventouse or forceps, fetal scalp, and so on. Otherwise, they can go for delivery, normal delivery under the coverage, which I have mentioned, like a major surgery and a major bleedings. Neonate, we need to test them. They are potentially a bleeding disorder, or they carry a risk for bleeding due to antibodies transferred from the mother. Postpartum hemorrhage, again, it is very common among the ladies with bleeding disorder, as you can appreciate it, and they need to be on tranexamic acid replacement therapy. And in most instances, it is late type of postpartum hemorrhage. So please, a bleeding disorder lady, keep them on prolonged type of tranexamic acid. This is some other type of gynecological problems. Stem cell transplantation is some certain type of bleeding disorder, such as Glasman thrombostenia or Bernard-Saurer or any other platelet function. It is a good tool to cure that patient. But be careful that there is a lot of complication with stem cell transplantation. In many occasions, bleeding disorder by itself, it is not that severe, so transplantation is not indicated. This is the indication for transplantation when the bleeding disorder interfere with the patient's life. So they cannot, frequent bleeding need to be admitted from now and then, and there is a lot of risk for bleeding disorder. I remind you, those patients with bleeding disorder, they have a lot of problems I have mentioned, and they need to be interaction between all the subspecialties for those patients. Last not least, gene therapy, it is the promise for bleeding disorder. We know now, coming to the market, the hemophilia. This is the first patient whom he had gene therapy, and I have permission from him to show this picture. He had done gene therapy for, he has hemophilia B, by the way, in 1999, and I was honored to be with him and his developer from Royal Free London. And thank you. I hope I didn't get more time. Feras.
Thank you, Dr. Ahmed, for an outstanding talk. Actually, also you managed the time very well. We'll move to the next speaker. It's my great pleasure to introduce Dr. Magdy Elekiaby. Dr. Magdy is a board member with World Federation of Hemophilia. He's also Vice President of Egyptian Hemophilia Society, as well as he has multiple positions, as well as several publications. Dr. Magdy, the floor is yours.
Thank you very much, Dr. Feras. First of all, I would like to express my thanks to Saudi Society of Blood Diseases, to Dr. Ahmed Tarawah, to Dr. Feras, and Dr. Azzah for allowing me to share in this very important meeting. I would also like to congratulate Dr. Azzah and Dr. Ahmed to cover a very wide topic in such a short time, and give me the opportunity even to focus more on the matters, specific matters related to von Willebrand disease. So as Dr. Tarawah assigned me to talk about how I treat von Willebrand disease. Now, if you look to the von Willebrand factor, I would say it looks like the aircraft carrier. It's a huge protein with several functions. I would highlight only 3 of its several functions. It is binding the platelets to the subendothelium in the case of tissue injury. It is facilitating the platelet aggregation at the site of the injury, and the factor, the von Willebrand is a carrier of factor 8, protecting it from premature degradation in the circulation. So as such, it is a very complex protein, and it needs several laboratory assays in order to assess its different aspects. So to measure the total protein, we need to do the quantitative von Willebrand antigen assay. The function of binding the platelets to the subendothelium, it needs the collagen binding assay. And then for the platelet-dependent von Willebrand aggregation, we need to do the binding activity or resuscitating cofactor activity or von Willebrand factor GPO1B, because there are several level assays now for this activity. And then finally, for its function as a carrier of the von Willebrand of the factor 8, we need to measure the factor 8 level itself, and probably also to measure the von Willebrand factor 8 binding activity. So if we come to the von Willebrand disease, von Willebrand disease is the result of reduced amounts or abnormal forms of von Willebrand factor in the circulation. So it has different forms in expression, and it was first discovered by Eric von Willebrand in 1926. And as an epidemiology, as Dr. Ahmed stated, that von Willebrand disease is one of the most frequent bleeding disorders. Some estimated its prevalence as 1 in 100, but it ranges from 1 in 100 to 1 in 10,000, and it affects both males and females. If we restrict the inclusion criteria to cases deserving medical attention and therapeutic or preventive interventions, largely corresponding to moderate to severe von Willebrand, then the figure of 1 in 10,000 seems to fit. And consistently, a higher frequency of the disease is reported in women due to physiological hemostatic challenges like menstruation and pregnancy. And I would like to thank Dr. Tarawah very much for covering the topic of bleeding disorders in women, because I'm not going into details of this due to the limitation of the time. If we look to the outreach to the disease, we find that the disease globally is still underdiagnosed. So if we compare the diagnosis of hemophilia, and if we assume that both hemophilia and moderate to severe von Willebrand has the same prevalence of 1 in 10,000, we find that the total number of diagnosed patients with hemophilia globally is 210,000, while still the von Willebrand disease is at the limit of 80,000. So we still globally need to do a lot of work to identify and outreach those patients with hemophilia. In Egypt, it's almost the same situation. If we look into the total registry, we have about 7,000 or close to 8,000 patients with bleeding disorders. Only close to 600 cases with von Willebrand disease are diagnosed. And this means that still the disease is very much under diagnosed. So, as I said, the von Willebrand disease will present due to the large protein, and the multiple functions will present in different forms. So we have the quantitative form, which is largely type 1, the milder form of quantitative von Willebrand disease, and its subtype type 1C, which is due to the enhanced clearance of the propeptide of the von Willebrand from the circulation, and the type 3, which is almost complete deficiency of von Willebrand disease. And then we have the qualitative type, which has 4 subtypes: the 2A, which is the loss of the higher molecular weight multimers; the 2B, which is increased avidity of the von Willebrand to the platelets; the 2M, the loss of function of the higher molecular weight multimers; and then the 2N, which is the loss of binding activity of von Willebrand to factor 8, leading to premature clearance of factor 8 from the circulation. And then we have the pseudo von Willebrand, which is enhanced activity of platelet to attach to von Willebrand, and also we have the acquired von Willebrand. It's very important to know the mode of inheritance. So all forms of von Willebrand are inherited as autosomal dominant, except for type 3 and type 2N, which are inherited as autosomal recessive. So consanguinity plays an important role in this type of von Willebrand for the severe disease. How to outreach? We need to know the symptoms or presenting symptoms, which is mainly mucocutaneous, except in the type 3, where also musculoskeletal bleeding can happen, similar to hemophilia, due to the very low level of factor 8 in this disease. We may look into family members of inherited bleeding disorders using the family pedigree, the bleeding assessment tools that was largely elaborated by Dr. Azzah and Dr. Tarawah, and then the hematological workup. Or we look into target populations with bleeding symptoms, where bleeding assessment tools are important in addition to the hematological workup. The WFH has a compendium of assessment tools, including MCDM1 von Willebrand bleeding questionnaire, bacterial blood loss assessment chart, ISTH bleeding tool, and all come with, the forms for filling such, and the explanatory documents, and the how to evaluate them. This is the example of the bleeding assessment tools, which are divided into general diagnostic tools and symptom-specific tools, like epistaxis scoring system, bacterial blood loss, and menorrhagia-specific screening tools. The laboratory workup would include blood count, blood grouping, because the blood group plays a role in the level of von Willebrand, where blood group O, they have von Willebrand levels about 30% less than in blood groups AB and AB. PT and APTT as a screening test, the von Willebrand antigen, the different types of activity, the factor 8 assay, the factor 8 von Willebrand, the von Willebrand factor antigen ratio, activity to antigen ratio, and the enhanced RIPA to diagnose von Willebrand type 2B, in addition to the collagen binding assay, which is more and more used. So if we look into the different explanations, we generally we would diagnose patients with von Willebrand if they have an activity level below 30% of activity. And we would, for the severe form, the von Willebrand factor and factor 8 are extremely low. For the qualitative type, we may have a normal antigen level, but reduced activity, which will reflect on the activity to antigen ratio, that it will be generally below 0.5 to 0.7 ratio. And this will indicate to us that it is a kind of qualitative type of von Willebrand disease. For those who have levels between 30 to 50 activity, we would consider them like persons with low von Willebrand factor. But if they have bleeding symptoms, then we would categorize them as low von Willebrand with bleeding tendency. Type 2N will need factor 8 binding studies or genotyping. And of course, here we need a reference laboratory is crucial for the classification of the type of von Willebrand, in addition to the multipolar analysis, which is not frequently available in everywhere, and it needs a highly specialized laboratory. I mean, right now, there is the writing of the new guidelines 2020 of diagnosis and management of von Willebrand, which is a co-work between the American Society of Hematology, the ISTH, the National Hemophilia Foundation in the US, and the World Federation of Hemophilia. And on the level of the diagnosis guidelines, the main questions that have been brought into, or the scoping questions that the guidelines will answer is several aspects. In patients who are suspected with von Willebrand disease, are we using the bleeding assessment tools to screen for the von Willebrand disease? Or not using the standardized clinical assessment tools? Do we do the blood testing or no blood testing if we have negative or normal bleeding assessment tools? In patients suspected with von Willebrand, do we use the von Willebrand resuscitating cofactor ratio to identify for accurate clinical diagnosis? The historic diagnosis of type 1 von Willebrand, but who now have normal von Willebrand factor. Do we reconsider diagnosis in patients with abnormal initial von Willebrand screen, low von Willebrand antigen, or platelet-dependent von Willebrand factor activity, and suspected type 1 von Willebrand? Is diagnosis of type 1 von Willebrand disease at a von Willebrand antigen and or platelet-dependent von Willebrand activity less than 0.3, 30 or 0.3 for accurate diagnosis, and so on. There is coming 10 questions, and the answers of these questions will be recommendations that will help to more enhance the accurate diagnosis and the typing of von Willebrand disease. Regarding the recommendations for the management, we have the ASH guidelines since 2012, and which is now might be upgraded in the 2020 guidelines. So the basic needs for the management, as highlighted by the 2012 guidelines, is the multidisciplinary teams, which was clearly highlighted by Dr. Tarawah. It should include hematologists, nurses, highly qualified lab capable of performing specialized von Willebrand disease diagnostic tests, obstetricians, other needed specialties, and the treatment products, which are mainly the DDAVP, the antifibrinolytics, and the von Willebrand factor 8 concentrate or purified von Willebrand factor concentrates. Regarding DDAVP, it was highlighted, the dose by its function is highlighted by Dr. Tarawah. It is a synthetic analog of vasopressin, and it helps to release the von Willebrand factor 8 from their endothelial stores. And we have two preparations, the ampoules for IV infusion or subcutaneous injection, and the spray or for intranasal inhalation, which comes in a potent preparation, not the one used for nocturnal enuresis. The dose is 0.3 microgram once per day for a maximum of 3 consecutive days. Recommended for von Willebrand type 1, particularly those having von Willebrand factor level above 20 international unit and factor 8 above 10 international unit. A therapeutic test is recommended before routine use to test for efficiency, and it is not recommended for types 2 and 3. For the concentrates, we have different preparations, whether plasma-derived, intermediate purity factor 8 preparations, and ones that like the Hemet P, which includes even higher levels of von Willebrand factor compared to factor 8 preparation. And then we have one recombinant factor, the Fonfendi from Baxalta. If these are not available, still in some countries, the use of cryoprecipitate per se is used, or more recently, the solvent detergent treated cryoprecipitate for viral safety. For the management of von Willebrand disease, normally we have to avoid salicylic acid and other non-steroidal anti-inflammatory as well as platelet binding drugs. For minor surgery, we may use DDEVP in combination with antifibrinolytics. We generally tend to increase the level of von Willebrand to above 30 international units and preferably above 50 international units for 1 to 5 days. And for management of minor bleeding with DDEVP and proper fluid restriction can be performed without electrolyte monitoring unless DDEVP is used more than 3 times in 72 hours. For mild to moderate von Willebrand, antifibrinolytics combined with DDEVP are generally effective for oral surgery. On treatment of major bleeding, all treatment plans should be based on objective laboratory determination of response of von Willebrand resuscitating cofactor activity and factor 8 levels to DDEVP or concentrates. For severe bleeding, intracranial or retroperitoneal or prophylaxis of major surgery, initial target should be more than 100 international unit and then maintain to above 50 international unit for at least 7 to 10 days. In all patients receiving von Willebrand factor concentrate, clinicians should perform proper thrombotic risk assessment and institute appropriate strategies to prevent thrombosis and to decrease risk of perioperative thrombosis. Von Willebrand resuscitating cofactor levels should not exceed 200 international unit and factor 8 activity does not exceed 250 international unit. What about prophylaxis? We know that in hemophilia, the prophylaxis is a gold standard. Now, what is the recommendation of using prophylaxis with clotting factor concentrates containing von Willebrand or purified von Willebrand? Mainly, the consensus now is to use it for heavy bleeders, defined by von Willebrand factor activity below 10 unit per deciliter and factor 8 below 20 unit per deciliter. Bleeding score above 10 if we are using the ISBH bleeding assessment tool, or occurrence of particularly GIT angiodysplasia with frequent bleeding. Product of choice for long-term prophylaxis should be the purified von Willebrand concentrate, whether plasma-derived or recombinant. There are not many studies about the efficacy of prophylaxis in von Willebrand. One, maybe the only with limited, many limitations, randomized trial was the one conducted by Pivandi in 2019, which was called the ProVil prophylaxis versus on-demand. It was a prospective randomized study, including 9 patients prophylaxis arm and 10 patients on-demand. Prophylaxis patients received Fandi alphanate 60 international unit von Willebrand resuscitating cofactor. And for clarity, I do not have any conflict of interest for any drug with a specific commercial brand. Per kg of body weight every 3rd day, patients with previous mucosal bleeding received the same dose every 2nd day. On-demand treatment, patients received 40 to 60 international unit von Willebrand resuscitating cofactor of body weight at onset of each bleed. And despite the small size, but it concluded that prophylaxis was superior to on-demand, but the study has a lot of limitations. Few complications may happen, like in type 3 von Willebrand with inhibitors. It is a rare occurrence. I experienced one case, and we used high doses of von Willebrand factor containing preparations, which helped to, at its stage, to reduce the intensity of the antibodies. But after some time, the antibodies became very aggressive. We used FEBA to bypass the bleeding. One common also complication of von Willebrand, particularly in type 3, is the development of angiodysplasia, particularly the GIT, which may expose the patient to considerable recurrent bleeding. And one of the aspects is the use of hormonal therapy or long-term prophylaxis of von Willebrand to try to manage these very difficult complications. As I said, one of the types of the von Willebrand is the acquired von Willebrand disease syndromes, which are due to defects of von Willebrand concentration, structure, or function that are not inherited directly, but are consequences of other medical disorders associated with monoclonal gammopathy, aortic stenosis, thrombocytosis, myelo or lymphoproliferative disorders. And it can affect the patients undergoing surgeries and other problems. Also, now under consideration in the new guideline, many questions like these questions: patients with von Willebrand disease and history of severe bleeding, do they deserve to be put in prophylaxis? Do we treat based on results of desmopressin, or we treat, ad hoc patients with von Willebrand disease and cardiovascular disease? Do we consider antiplatelet agents or anticoagulants? Do we keep factor levels, factor VIII levels above 50, and so on? There are many questions, and we hope that the guidelines, I think maybe they will be ready by the time of the ASH this year. So the take-home message of my presentation is that von Willebrand disease is a complex inherited disorder with variable clinical and laboratory presentations. Bleeding assessment tools and family history are important tools for outreach of von Willebrand disease. There is a need for GLP specialized lab facility, multidisciplinary approach for management, and strategies for replacement therapy, including prophylaxis. Thank you very much.
Thank you, Prof. Magdy, for an elegant talk. So now we'll start the next session, which is about the Q&A. So we did receive several questions. So I will start with Dr. Azzah. So there is a question regarding many patients with factor VII deficiency has been diagnosed as part of preoperative workup. So how would you take that? Since you mentioned that we have to be selective in doing the coagulation preoperatively.
Okay, good question. First, for example, factor VII is rare. It's not that common, the factor VII deficiency. And then for rare disease, to do screening for thousands and thousands patients going for the surgery to pick up very rare disease, this is time consuming and also financial consuming, a lot of stress on the family, because yes, we could have like maybe even hemophilia, first diagnosed by circumcision, and there is no family history. But again, all this is very rare. To do screening for 1,000 patients to pick up those rare disease. It could replace easily by the history. But we have to have a standardized questionnaire. So this is going to be very helpful. Incident, yes, it could happen. You could have some patient who, but if I do again screening for everybody, there is with the coagulation like BT and BTT without history, he may have something else which not picked up by the BT and BTT, like maybe he has von Willebrand, which is normal sometimes BTT. Maybe he has platelet dysfunction, factor 13. So I think still history is very important rather than to do screening just for a rare disease. Thank you.
Thank you, Dr. Azzah. There was another question about coagulation workup before dental. The answer will be the same. History is the most important. Another question, Dr. Azzah, is how would you differentiate between factor VIII deficiency and von Willebrand, especially that some von Willebrand will have a low level factor VIII?
Sure, yeah. Like if you have factor VIII initial diagnosis, hemophilia, we have to do von Willebrand. You cannot diagnose only hemophilia without von Willebrand because there is a lot of maybe mistaken between maybe he is a type of von Willebrand, either mild or moderate or whatever, and he is not hemophilia. So it's from the panel of the test. Like if you have diagnosed factor VIII is low, we have to include von Willebrand factor and activity. And maybe Dr. Magdy also, he commented this. You cannot diagnose hemophilia without von Willebrand. So by this way, you can differentiate. If he had normal von Willebrand factor, only factor VIII, so most likely he's hemophilia case.
Dr. Magdy,
what do you think, Dr. Magdy?
Comment?
Yes, I think, I mean, it depends on two aspects. What is the mode of inheritance? So let's say it's mainly in male and it's the family history. There is a positive family history of hemophilia. This will help us to categorize as hemophilia. The level of the factor deficiency, if we have, I mean, the severe hemophilia below 1% is most probably, and the type of bleeding, the musculoskeletal bleeding, which is the predominant presentation, might help us to say that this is hemophilia. If you have levels like the mild hemophilia above 5%, then it's better to do the differential diagnosis by doing the von Willebrand factor antigen and activity as well, because sometimes the antigen is normal but the activity is different. So which may I mean help confuse us on the diagnosis of mild hemophilia or the type N von Willebrand factor disease.
Thank you. So there's a question for Dr. Tarawah. How would you prepare a pregnant lady for delivery, vaginal delivery or C-section, who's having a factor V deficiency?
As I said earlier, that it should be very well planned, particularly when we know that factor V deficiency is one of the extremely rare types of deficiency, and we don't have enough experience to do so, and we don't have factor V concentrate, so we will use the fresh frozen plasma. So preparation for delivery, it is, I think normal delivery will be the mode of delivery, though that if the father is carrier for the disease, so the risk of the baby to be factor V is there. Despite that, we will go for the normal delivery. We start earlier in the first stage. We prepare the patient. Tranexamic acid will be a very good tool of management. Fresh frozen plasma once she will go into the second stage, and we will continue during the third stage and after delivery, and probably for 2 to 3 days we will continue FFB till we reassure that there is no postpartum hemorrhage for that lady. Immediately after delivery, we need to test the baby for deficiency, and we need to look for the intracranial hemorrhage in those babies as early as possible. So if he need management, we can start earlier.
Okay. I know you answered this. There is another question about preparation before dental clinic. So this is a repeated question I received. How would you briefly?
Well, very quickly, for the hematologist, preparation, it depends on the disease by itself. So when somebody going to the dentist, this is what I do usually. I ask the dentist what the procedure you are going to do. Number two, is this high risk for bleeding, or are you going to use some sort of anesthesia block or so? So I understand what is the risk of bleeding. Then accordingly, I'll do. If it is just workup, simple workup, tranexamic acid alone will be enough, and I'll continue tranexamic acid after. If it is more risky for bleeding, what depends on the type of bleeding. So I'll use the replacement therapy immediately after they go to the dentist. And for example, in factor 13, 1 dose before the dental workup is enough. For factor 7 deficiency, he needs to continue after the dental workup. So it depends on the risk of bleeding and the nature of bleeding disorder.
Thank you. Dr. Magdy, there is a question for a 3-year-old child with von Willebrand type 1, and he has been receiving DDAVP for petechiae and ecchymosis. So would you recommend giving DDAVP for that? And what would you give? And what would you offer him other than DDAVP, because he's not responding to it?
Yeah, I mean, the guideline says that we need to do a DDAVP test, because not all the patients will respond to DDAVP. So there is a therapeutic test if he responds or not. And this is usually by measuring the activity at baseline before injecting the baby, and then giving the dose at 0.3 microgram per kg infusion. And then in 2 or 3 hours, we measure again the rise of the von Willebrand factor. Of course, we need to make sure that it is truly type 1 von Willebrand, and it's not any of the other qualitative or the severe type of von Willebrand. So the lab here is very important to determine these parameters. And as we said, that the propeptide type, which has a clearance, and I think it may be like 20% of cases of type 1 are this type 1C, where there is enhanced clearance of the von Willebrand propeptide from the circulation. So in these situations, we don't expect that the improvement with the DDAVP will happen. So these are important things that we take into consideration when we are intending to use DDAVP for the treatment of it. So if it is ineffective, then the second is to use the concentrates instead of the DDAVP. Of course, also in the young children, we need to make sure that we do not use it for a long time because of the effect of the hypernatremia, and we have to do the fluid restriction in these situations. So if with all these measures, if we identify that the DDAVP is not effective, then the alternative is either, if it is a mild bleeding, the use of antifibrinolytics. If they are not effective as well, we use the concentrates.
Okay, so there's a question for Dr. Tarawah. So 20-year-old woman with recurrent bleeding secondary to factor 2 deficiency. How would you manage her other than FFP and PCC?
The factor 2 deficiency? Did you say factor 2?
Factor, it's written factor 2. I don't know if he meant something else.
I'm not quite sure if he means factor 2, because usually factor 2 deficiency, we don't call it factor 2 deficiency. It's something related to thrombin, or he means something else. I'm not sure if he means thrombin. My answer, it's I don't know. It's FFB. It's 1 in 3 or 4 million, so we don't have experience with that. If he means thrombin deficiency. But the only treatment we do have, it is FFB. He can try FFB. Maybe 7A will do some job in those patients. If he means fibrinogen, the matter is different. I'm not sure.
Any other comment from the panelists?
The prothrombin, it's type 2 is the prothrombin deficiency, and it is the rarest type of rare bleeding disorders. It's 1 in a million population, so it's very, very rare. And as Dr. Tarawah said, it's either the FFP or the prothrombin complex concentrates, which contains among its constituents the factor 2, or the finally, more probably the FIBA, which is the activated prothrombin complex concentrate, if available, can be used.
Okay. There is another question is last. So we do see more direction toward cryoprecipitate than factor 8 to avoid antibody formation. What are your thoughts?
Oh, okay. I mean, the inhibitor formation is multifactorial. It's not a single factor. So product type is not of paramount importance to prevent inhibitor formation. The studies in this situation is bizarre. Historically, the use of cryoprecipitate and FFP reports on the formation of inhibitors was, of course, much less than the current concentrates. But we need to bear in mind that these studies were at a time where these studies were not, properly planned and conducted as it happens today. Meaning the prevalence of inhibitor development in the previously untransfused populations and so on. From our side, we have a small cohort that uses the pups that use the solvent detergent cryoprecipitate for now 10 years. Actually, there was no inhibitor development, but I cannot correlate this with the type of the product. It's more that starting the prophylaxis very early before the development of arthropathy, which enhances the inflammatory factors that, like the interleukins and the ongoing process, that you do not use the concentrate in high bleeding events, all the risk factors that may result in the formation of inhibitors. So, I mean, I cannot recommend that cryoprecipitate would be used as an alternative to the factor. Probably, if there is no availability, it is there, but or the virally inactivated will be a better step, or the best is are the concentrates, but to be used rationally to reduce the inhibitor formation.
Thank you, Dr. Magdy. Question for Azzah. So if you have a patient with a bleeding tendency and all investigations are normal, except factor 13, which is not available, how would you manage this patient? What are your recommendations?
Okay, like if by the history he has bleeding tendency, and especially for factor 13, like even in neonatal period, it can help, like the history of umbilical cord separation, family history, and if all coagulation still we need, like you cannot expose him for surgery if there is any history or any suggestion of bleeding disorder in the patient himself, or in his like by history of himself or in the family, and expose him for the surgery without know what is it, what's the underlying problem. So to be stand by to correct what's going on, either factor 13 or something else. So I think still they shouldn't, usually we even in our hospital, sometimes we send it abroad for factor 13. It's not always available in, but like they can do screening for the urea dissolving, like in the lab, they know how to do it. Can they detect there is a defect in the factor 13? So like to manage patient without knowing what's the underlying disease, I think it's still like it's difficult. Sometimes in emergency, if there is any bleeding, you give him fresh frozen plasma, cryoprecipitate if you don't know. Like this is for emergency, but for elective things, it's better to work him up to know what's the underlying problem. So you prepare yourself for that.
And another question regarding platelet level and major surgery. When would you clear patient for a major surgery based on his platelet level?
Sorry again, doctor?
Platelet level and major surgery.
Usually the normal number of the platelet from 150. So for surgery, if above 100 is fine, but again, according to what type of the surgery. Usually neurosurgery, ophthalmology, they need the above 150. Some of the surgery you can go with 100, above 100, but definitely major surgery not below 100.
Question for Tarawah. Menorrhagia secondary to one Willebrand in 14 years old female. How would you treat it? I mean, the type is not mentioned, unfortunately.
حول السؤال للدكتور مجدي. Von Willebrand, Dr. Magdy with menorrhagia. I'm trying to escape.
Dr. Ahmed, you know it. I mean, Dr. Ahmed elaborated on it clearly in his, options. What options, do we, the lady will give us to manage? Does she want to get pregnant now? Does she is not interested in getting pregnant immediately, or she is not interested in keeping her fertility? And accordingly, we will work out. So if she wants to get pregnant, then the hemostatic agents will play the paramount role, and the antifibrinolytics. If she is not interested immediately, then the hormonal therapy, in addition to the antifibrinolytics, and in severe cases, the concentrates will play the important role. If she is not interested at all, then the ablative surgery or a hysterectomy is the choice to give a better quality of life to this lady.
Okay, last question I have is, so it's not clear, but I will share it with you. So one Willebrand level was normal. Patient was given DDAVB, and one Willebrand test dropped, and factor 8 also dropped. How would you interpret it?
Yeah, this can sometimes happen in one of two situations, either in the type 2B, when we give DDAVP, because the high molecular weight multimers are there, they are not trimmed, and so they interact more with the platelets, resulting in thrombocytopenia and decrease in the von Willebrand factor, or in the platelet type von Willebrand, because of the increased avidity, will express more von Willebrand, which will interact more with the avid platelets and will result in drop in von Willebrand as well as in the platelet count.
Okay, that was the last question. So I would like to thank our renowned faculty, Dr. Magdy, Dr. Tarawah, Dr. Azzah. I would like to thank all the attendees for making it a very interactive and fruitful session. I'd like to thank Nada from SSPD. Stay safe.
Thank you very much. Bye-bye.